Hi, it's Mike Carberry with Advanced Medical Integration, founder of Advanced Medical Integration. I want to talk to you about what an integrated medical practice looks like. So it's funny, 25 years into this, 27 years into practice, the word integration is now becoming a buzzword for the first time. Whereas when I first started back in the 90s, people were like, what's integrated? So let's take a look. What does an integrated practice look like? So when I first started, everybody was calling it multidiscipline, or they called it MDDC, meaning the medical doctor chiropractor. And the integrated word for us is the most accurate one, but let's see what they mean. So a multidiscipline practice means that you have medical professionals, doctors, chiropractors, medical doctors, nurse practitioners, PAs, osteopaths, all working in the same practice. So you have different licenses working in the same practice. That's multidiscipline. Integrated means different licenses working on the same patient. That's different. Working as a team on the same patient. We teach, and we've always done, an integrated model. Let me tell you where it comes from. So my wife is a physical therapist, and her specialty, when I met her, she was doing traumatic brain injury and stroke rehabilitation. That is a very complicated, difficult, and thankless aspect of physical therapy. Most of her patients, 70% of her patients, when she got them, were in a coma. And the first thing they had to do was bring them out of a coma. So the way they would do this is they would work as a team. A physical therapist, an occupational therapist, a speech therapist, and a cognitive therapist, all working on the same patient under the direction of a medical doctor who specialized in physical medicine called a physiatrist. That's the team she was working on. They would have a team meeting several times a week. And the team meeting was to actually keep everybody on the same page because they are co-treating the patient. The idea here is that it is a much better outcome to the patient because you have different thought processes or viewpoints coming from the different professionals. The occupational therapist and the speech therapist would look at it differently than the cognitive therapist and the physical therapist. And to keep them all on the same page, there was a physiatrist who had the senior license. The physiatrist is a medical doctor. So when my wife, when we had our first child, I was in chiropractic school, and our daughter Amanda was, when she was a baby, I used to take her to school. And I would have to, at lunchtime, Colleen would want to breastfeed because she got engorged at work, so I'd drive her over to the hospital whenever I could, and she could breastfeed the baby. And sometimes I'd get there before, she was ready to take a break for lunch, and I would have to sit in the hall waiting for her to come out of this meeting. It was a team meeting. And I would hear this meeting going on where the physiatrist was asking each of the professionals their opinion, and they were collaborating, meaning working together for a better outcome. That's a true integrated practice. Most other consulting companies are teaching multidiscipline. Oh, bring this service on, bring this service on, bring this service on. And it's not always in a jointed or a collaborative way, it's in a disjointed way, meaning all working independently. Well, you got this service, you can increase your income. The concept there is the professionals are thinking there's only 3 ways to increase or expand your business. That is, raise your prices, increase your volume, or increase the number of services you offer. And so they look at a multidiscipline model. They call it integrated, but I don't think it even dawned on them what integrated means. It's working together on the same patient. That's what we've done from the very beginning. There are a lot of people that came into my practice in Pennsylvania when I was doing this and saw these team meetings and thought, wow, this is really different. I've never seen anything like this. A lot of people who work in hospital systems, especially in units like the head injury unit, saw this model. And everybody I've ever spoke to who worked in a model like this, no matter what aspect of healthcare it was, they totally respected the model because you get the viewpoints of different professions working together. So we created this team meeting concept to keep everybody on the same page and working together. The basis of the care plan was, remember, if you've heard my story before, we noticed patients coming in with chronic degenerative problems in a chiropractic office, a very, very busy, large volume chiropractic office, and we realized they needed more than just adjustments. We realized that when you injure the spine, the head goes forward. That forward head translation means you start using different muscles to hold your body up, and it starts a process that gets those shoulders to round and the head to go forward and the back to hump. And if it's left unchallenged, eventually the patient will be an old person walking very stiffly and weakly and bent over. The reason that happens is when you start to transition the body, you start to recruit muscles to do the job of holding you up. So if you remember from physiology class, there are muscles of motion, and they're called phasic muscles, and there are muscles of posture. They are called postural muscles. A postural muscle is a muscle that you use on a long-term basis to hold your body up. But it doesn't have to be very strong, and it doesn't have to be with a long range of motion. So it has a short range of motion. They tend to be weaker, but they tend to be, they possess the ability to have tremendous endurance. You can hold your body up sometimes if you pull an all-nighter for 2 days straight. But by the end of that second day, you're usually going like this and trying to hold your head up because the muscles are fatigued. Whereas a muscle of motion, like the bicep, a phasic muscle, you can't pick up a heavy weight and hold it there. Like you couldn't take a bowling ball and hold it out in front of you for hours and hours and hours. In a couple minutes, maybe even a couple seconds, the muscles are going to fatigue and you're going to start shifting the way you're holding it to recruit other muscles until you can't do it anymore. Well, that's exactly what your body does when you injure the spine, and it goes through this chronic degenerative process. So what we do is we have to look at the whole picture. We have to see orthopedically, what is that patient complaining of? And what is the pain that brings them into that office? And we have to explore that. But if we're trying to fix the cause, if we're trying to find the functional deficit and fix that, well, we got to do some exploring and find out what's actually the cause of that problem. For example, if somebody has a knee complaint, we're not going to use tunnel vision in this model and look at just the knee. We're going to look at the whole picture. What caused that knee problem? Why did that knee wear out faster than that knee? And what we find is sometimes when this is the painful knee, this is the degenerated knee. This knee is usually, it can be worse. And that's like a third of the time. The reason for that is the body adapts. Somebody develops problems with this knee and they start to shift their weight, put more weight bearing on this knee, and this one starts to hurt first when really that's the culprit. So when we look at that person, we really got to look at both knees. Well, the Q angle is the angle that the femurs come down out of the pelvis and articulate with the knees, and they should be at a certain angle. If the pelvis is misaligned, that Q angle is going to be different and accelerate the degeneration of those knees, and differently because it's a different angle. So you have to now look at the pelvis. And if you look at Rene Callier's work, he says if there's a problem with the pelvis or L5, that could translate into forward head carriage. So now you got to look at the whole body. If you're going to fix the patient, you got to look at the whole body. I'll give you another example. I'm going to sit up straight here to show you. The supraspinatus muscle is one of the rotator cuff muscles. It starts in the back, comes up and translates underneath the acromion process and attaches to the front of the humerus. So what happens is it's the most commonly injured muscle in the rotator cuff. When people usually get rotator cuff surgery, it's usually to repair that muscle. And my wife showed me a study years and years ago where they looked at males 45 years old and found out that over 50% of asymptomatic patients, they had no shoulder problems, had decreased blood flow to the distal end of the supraspinatus where it attached to the humerus. And you go, why would that be? Why would they have not enough blood flow to the end of that muscle, which is why it tears so easily? Well, watch my shoulders. As my head goes forward, you'll notice my shoulders are starting to round forward. And when you round forward, you stretch that muscle, which goes underneath the acromion, and it starts to cut off the blood flow. So if you have a patient that has a rotator cuff problem and they go get surgery and nobody fixes the posture, guess what's coming back? The shoulder problem, which is why people have repeated rotator cuff shoulder surgeries. If you're going to fix it, you got to fix the posture. You got to fix the whole thing. That's a functional viewpoint versus a symptomatic viewpoint. Now, the insurance companies could argue, well, they got the surgery, so that other work is just extra money. Well, it's a lot less expensive than the second surgery. And it's a better outcome and more function and more lifestyle for the patient. So we have to shift our viewpoints. But an integrated practice takes this approach. We look at it from a different different viewpoint and ask the question, why? Why does an integrated practice, or why does the patient have this problem? What can the integrated practice do to prevent it from coming back? Let's try to get them back to 100% of normal as quickly as possible, and in the best possible fashion. So if you do that, there's less likelihood of complications in the future. So we have to look at the whole picture, and we have to figure out, what do they need? Do they need exercises to bring that posture back? If they do, we're going to recommend them. Do they need injections to break up adhesions in those joints? If they have degeneration, we're going to do that. Do they need stem cells that could help regenerate and cushion that joint and make it function better for a much longer period of time? Well, if they need that, we're going to recommend it. Do they need a brace to hold that knee at the correct angle? Knees usually degenerate medially 85% of the time, laterally 15% of the time. So whether it's degenerated laterally or medially, we're going to want to brace it to hold it at the correct angle so that when we rehabilitate that knee, it's going to function at its optimum. And we're going to use a brace that allows movement so that we're not restricting the motion of the knee. If they have a back problem, if there's degeneration in the back, we're going to want to decompress that using a decompressive brace that molds to the patient's body and helps to decompress that disc. And we're going to want them to wear it a couple times a day and wear it whenever they're doing any heavy lifting or whenever they're having pain, because we'd rather them do that than to actually take medication. So you're looking at this complete picture. You want to make sure the patient's getting better. So you have to have a system to measure, not one point system, but a multi-point system where you can measure the improvement of the patient. We used to break our functional exam down into points, and I think we came up with like 350 points. And we could measure at each re-exam, which we do every 2 weeks, when we tally up the points. Well, if there was a potential of 350 points and the patient came in only scoring 108, well, if we get them to 115 by the first re-exam, we go, all right, we're in the right direction. If we get them to 150, then 170, then 210, then 250, and we're moving in the direction, every point we gain back for that patient is improved lifestyle. Their symptoms will stop way early on that line, but we're measuring by function, so this is what we do. So that's what an integrated practice does. At every team meeting, which we do before every shift, all of the practitioners get together and they collaborate. And they talk about the re-exams and the points and the condition on the x-rays and the degeneration. And they start this from the beginning and carry it through every 2 weeks until we discharge the patient, because they've achieved maximum medical improvement. And we know that because we're measuring it through our point system. So that's how we do it. That's what an integrated practice should look like. What do we treat? Well, some people say, well, can I be a family practice? Sure, you can be a family practice, but that's not really an integrated practice. If you looked at what we do, we look at the overall patient, and we're treating one specific thing, and not just one specific thing, but let me elaborate. If you were to ask me, what's your elevator speech of your business? I would say, we are a clinic that treats chronic degenerative arthritis and reverses the associated postural distortions that come from that. Well, that has a tremendous impact on the patient's body. For example, when the head goes forward, Renee Callier, Dr. Renee Callier, a medical doctor from Southern California, a physiatrist, documented that when you stretch, you go forward, you stretch the esophagus. When you stretch the esophagus, you slow down peristalsis, which is the wave of concentric rings that push that food all the way through your GI system. If you slow down peristalsis, you'll prolong that food in your GI system, and when it's toxic, as it would be in the colon, you're going to basically have toxicity in the colon longer, which could create all kinds of problems, including possibly even colon cancer. So forward head carriage could cause a problem like that. Forward head carriage has been documented to compress the lungs, which can decrease oxygen exchange and decrease the oxygen content to your body, particularly to your brain, which is not going to be good. And some people theorize that could be a cause or an aggravation of Alzheimer's. Certainly less oxygen to your brain is not as good as more oxygen to your brain. And then the forward head carriage also compresses the heart, which makes it work harder, which can cause the heart to enlarge, creating a condition called cardiomegaly, which can contribute to the largest killer in the United States, and that's heart disease. So we start addressing these things, people are going to get better. Are we going to fix everything? No. But is their body going to be in a better shape to handle those other things? Yes, because we're getting the core balanced and the posture strong. a lot of times we get people working these muscles. We live a very sedentary life in the United States. One of the side effects we notice of a lot of patients who go through our rehab program is they lose weight, usually about 15 to 20 pounds, because they're now using muscles they haven't used. Losing 15 to 20 pounds, any researcher on earth can tell you that's one of the best things you can do for a diabetic. You strengthen the muscles, you enhance the metabolism of those muscle cells, which can change your whole diabetic profile. So is it going to cure diabetes? Maybe, maybe not, but it'll certainly help that person. Any author in the world knows that the best thing you can do for heart disease, diabetes, asthma, digestive problems, depression, and many other conditions is lifestyle change of changing how you eat and changing how you use your body. And that is the hardest thing to get patients to do. This clinic focuses on getting their posture correct, their spine and their joints strong, and rehabilitate that degenerated joint in an integrated fashion. Multiple licenses working together with the knowledge they have to get the best possible outcome for the patients. So a true integrated practice is focusing on that niche that can have effects across the healthcare board. The other thing I want to just point out to you is that that niche is the #1 health complaint that human beings suffer with. The Archives of Internal Medicine and the Journal of the American Medical Association both published articles in the past saying the #1 reason to be in a hospital is to be born, and the #2 reason to be in a hospital is chronic degenerative arthritis, specifically back pain. So when you look at addressing that segment of the population, it is the largest segment, and that physical problem they're having can have large, impactful effects on other aspects of their health. So in addressing this, you're doing probably more for that patient than any other doctor they've ever been to. So that's what an integrated practice, in my viewpoint, a true integrated practice looks like. And hopefully we can get you to get your practice to be the same way. It works very well, it's great for the patient, it's compliant, and it is profitable. So thank you for listening.